As a clinician responsible for the care of patients with COVID-19, I see the ongoing burden this disease places on patients, families, and health systems. Hello, my name is Deitelzweig, and I'm a practicing hospitalist at Ochsner Medical Center in New Orleans. Today, I'll be sharing data supporting the appropriate use of VEKLURY, remdesivir 100 milligrams per injection, and dexamethasone in the treatment of adults hospitalized with COVID-19. VEKLURY is an antiviral medication indicated for the treatment of COVID-19 in adults and pediatric patients less than 18 years of age weighing at least 1.5 kilograms who are hospitalized or not hospitalized, have mild to moderate COVID-19, and are at high risk for progression to severe COVID-19, including hospitalization or death. VEKLURY is contraindicated in patients with a history of clinically significant hypersensitivity reactions to VEKLURY or any of its components. Now let's begin our discussion with a review of the guidelines. The National Institutes of Health, the Infectious Disease Society of America, and the World Health Organization have published clinical guidelines for the treatment of COVID-19. While VEKLURY and dexamethasone are included as recommended treatment options in all three, the purpose of this video, we will focus on the NIH guidelines, which include recommendations for a range of disease severities in hospitalized adults. In clinical practice, most patients admitted with a primary diagnosis of COVID-19 require some level of oxygenation, either low or high flow. There is also a subset of patients who do not require supplemental oxygen. Let's focus our attention on the guideline recommendations for these groups. For patients not requiring supplemental oxygen, the NIH guidelines recommend VEKLURY monotherapy for those who are at high risk of progression to severe disease. In my experience, most patients admitted for COVID-19 qualify as high risk based on the CDC criteria, which include older age, presence of certain underlying medical conditions such as asthma, COPD, obesity, or diabetes, or being unvaccinated. For all patients in this category, dexamethasone or other systemic corticosteroids are not recommended unless they are being prescribed for some other underlying condition. For patients requiring low-flow oxygen, the combination of VEKLURY with dexamethasone is recommended for most patients, although VEKLURY monotherapy can be considered for patients who require minimal conventional oxygen. For patients requiring high-flow oxygen or non-invasive ventilation, dexamethasone with immunomodulator is recommended for all patients. The guidelines state that VEKLURY can be added to this regimen for patients who are immunocompromised, have evidence of ongoing viral replication, or those who are within 10 days of symptom onset. Here is a summary of those recommendations. Notice that regardless of disease severity, dexamethasone monotherapy is not a recommended treatment option unless an antiviral and/or immunomodulator cannot be obtained or is contraindicated. At my institution, we utilize these recommendations to guide treatment decisions and inform our inpatient COVID-19 protocol and order set. In spite of the guidelines, the use of dexamethasone monotherapy appears to be a common practice at many hospitals. In fact, an analysis of data from October 2024 to March 2025 reported that dexamethasone monotherapy use in an average of 14% of patients not on supplemental oxygen and 27% of patients on low-flow oxygen. So where does the evidence lead us? Specifically, what data makes the case for VEKLURY as an evidence-based treatment for hospitalized patients with COVID-19? Let's start with ACT-1, as that was the pivotal inpatient NIH-sponsored clinical trial that led to the FDA approval of VEKLURY. ACT-1 was a randomized, double-blind, placebo-controlled clinical trial in adults hospitalized with mild, moderate, or severe COVID-19. Patients were randomized to receive either VEKLURY or placebo for up to 10 days. The primary endpoint was time to recovery within 29 days after randomization based on an 8-point ordinal scale, and recovery was defined as no longer hospitalized or hospitalized but no longer requiring ongoing COVID-19 medical care. As the results show, VEKLURY shortened recovery time by 5 days, and the frequency of adverse reactions was comparable between VEKLURY and placebo. FACC also evaluated mortality as a pre-specified secondary endpoint. Overall mortality at day 29 was not statistically significant. As you can see here, the confidence interval crosses over 1. However, FACC was not powered to evaluate a difference in mortality in the overall population. In a post hoc subgroup analysis, VEKLURY was associated with a 70% reduction in mortality of patients on low-flow oxygen. No significant difference in mortality was observed in the other subgroups. For me, the results of this early clinical trial were compelling at the time. However, the evidence for VEKLURY has evolved since then. Numerous real-world studies have been published, supplementing clinical trial results, supporting guideline recommendations, and informing clinical practice. Let's focus our attention on one of them. Before reviewing the real-world analysis, let's go over some general considerations to keep in mind. First, it's important to look at the type and size of the source datasets and methodologies used to address confounding or bias. Ask yourself, how do these factors contribute to the study's validity? Next, think about how the study fits within the context of all available data. How does this study contribute to what's already known? Finally, study results may vary, so consider other real-world evidence when applying these data. The study here was a large real-world retrospective comparative effectiveness study examining inpatient mortality in adults hospitalized for COVID-19 who were treated with VEKLURY plus dexamethasone or dexamethasone monotherapy. It included patients hospitalized from December 2021 to April 2023 during the Omicron variant period. The primary endpoints of this study were 14-day and 28-day all-cause inpatient mortality, with mortality being defined as a discharge status of expired or hospice. Data for the analysis were obtained from the PINC AI healthcare database, which is a U.S. hospital-based service-level all-payer database representing about a quarter of all U.S. hospitalizations. Using one-to-one matching without replacement, approximately 33,000 VEKLURY plus dexamethasone patients were matched to 33,000 dexamethasone monotherapy patients. Key factors that were matched include age, gender, concomitant treatments, baseline supplemental oxygen, ethnicity, comorbidities, and hospital characteristics. Before matching, VEKLURY plus dexamethasone patients tend to be younger, had lower rates of renal disease and diabetes, were more likely to have been on high-flow oxygen or non-invasive ventilation, and were less likely to have been on invasive mechanical ventilation or ECMO. After matching, characteristics were well-balanced. The strengths of this study were they applied two well-established statistical methods to balance inherently different groups due to confounding by indication. Additionally, consistent results were obtained with each statistical method. The study also included a large population of patients with a COVID-19 diagnosis from a multi-center administrative database, and it complemented and built upon existing research in COVID-19. The limitations include the potential for residual confounding due to imbalances in unmeasured variables between treatment groups. Also, certain information not in a database cannot be accounted for, including time of symptom onset, time since first positive COVID-19 test, vaccination data, and use of antivirals or any other treatment prior to hospitalization. Finally, patients from hospitals that did not report any charges for low-flow oxygen were not included in the no supplemental oxygen group to ensure uniform reporting. Ultimately, the study found that VEKLURY plus dexamethasone was associated with a 26% reduction in 14-day mortality risk and a 24% reduction in 28-day mortality risk in the overall population compared with dexamethasone monotherapy. And as you can see here, this statistically significant reduction in mortality risk was observed across all oxygen requirements at both 14 and 28 days. Since other corticosteroids may be used in clinical practice, an additional propensity score matching sensitivity analysis was performed to compare VEKLURY plus a corticosteroid with a corticosteroid monotherapy. Corticosteroids included in this analysis were prednisone, prednisolone, methylprednisolone, hydrocortisone, and dexamethasone. Consistent with findings from the dexamethasone analysis, VEKLURY plus a corticosteroid was associated with reduced mortality risk across all supplemental oxygen requirements compared with corticosteroid monotherapy. The results of this real-world study align with COVID-19 guideline recommendations regarding the appropriate use of VEKLURY and dexamethasone. And for me, these data reinforce my clinical practice of making VEKLURY standard of care for all appropriate inpatients with primary COVID-19. To summarize, results from a clinical trial and real-world study strengthen existing COVID-19 treatment guideline recommendations for the use of VEKLURY. However, claims data suggests that some inpatients are receiving inadequate care with dexamethasone monotherapy when a combination with VEKLURY would be appropriate. From my experience, outdated institutional protocols or a lack of familiarity with contemporary data can contribute to this dexamethasone monotherapy trend. To help address this gap in care, clinicians can ensure their treatment decisions and inpatient protocols are aligned to the latest evidence. As we conclude, let's review some important safety information. Hypersensitivity, including infusion-related and anaphylactic reactions, have been observed during and following administration of VEKLURY. Most reactions occurred within 1 hour. Monitor patients during infusion and observe for at least 1 hour after infusion is complete for signs and symptoms of hypersensitivity as clinically appropriate. Symptoms may include hypotension, hypertension, tachycardia, bradycardia, hypoxia, fever, dyspnea, wheezing, angioedema, rash, nausea, diaphoresis, and shivering. Slower infusion rates of up to 120 minutes can potentially prevent these reactions. If a severe infusion-related hypersensitivity reaction occurs, immediately discontinue VEKLURY and initiate appropriate treatment. Transaminase elevations have been observed in healthy volunteers and in patients with COVID-19 who receive VEKLURY. These elevations have also been reported as a clinical feature of COVID-19. Perform hepatic laboratory testing in all patients. Consider discontinuing VEKLURY if ALT levels increase to greater than 10 times the upper limit of normal. Discontinue VEKLURY if ALT elevation is accompanied by signs or symptoms of liver inflammation. Co-administration of VEKLURY with chloroquine phosphate or hydroxychloroquine sulfate is not recommended based on data from cell culture experiments, demonstrating potential antagonism, which may lead to a decrease in the antiviral activity of VEKLURY. The most common adverse reaction experienced by greater than or equal to 5% in all grades was nausea. The most common lab abnormalities experienced by greater than or equal to 5% in all grades were increases in ALT and AST. Administration should take place under conditions where management of severe hypersensitivity reactions, such as anaphylaxis, is possible. For patients who are hospitalized, VEKLURY should be initiated as soon as possible after diagnosis of symptomatic COVID-19. For patients who are hospitalized and do not require invasive mechanical ventilation and/or ECMO, the recommended treatment duration is 5 days. If a patient does not demonstrate clinical improvement, treatment may be extended up to 5 additional days for a total treatment duration of up to 10 days. For patients who are hospitalized and require invasive mechanical ventilation and/or ECMO, the recommended total treatment duration is 10 days. For patients who are not hospitalized, diagnosed with mild to moderate COVID-19, and are at high risk for progression to severe COVID-19, including hospitalization or death, the recommended total treatment duration is 3 days. VEKLURY should be initiated as soon as possible after diagnosis of symptomatic COVID-19 and within 7 days of symptom onset for outpatient use. Perform hepatic laboratory and prothrombin time testing prior to initiating VEKLURY and during use as clinically appropriate. No dosage adjustment of VEKLURY is recommended in patients with any degree of renal impairment, including patients on dialysis. VEKLURY may be administered without regard to timing of dialysis. Available clinical trial data for VEKLURY in pregnant women have not identified a drug-associated risk of major birth defects, miscarriage, or adverse maternal or fetal outcomes following second and third trimester exposure. There are insufficient data to evaluate the risk of VEKLURY exposure during the first trimester. Maternal and fetal risks are associated with untreated COVID-19 in pregnancy. VEKLURY can pass into breast milk. The developmental and health benefits of breastfeeding should be considered along with the mother's clinical need for VEKLURY and any potential adverse effects on the breastfed child from VEKLURY or from an underlying maternal condition. Breastfeeding individuals with COVID-19 should follow practices according to clinical guidelines to avoid exposing the infant to COVID-19. Thank you for joining me for this video. To learn more about VEKLURY clinical trials and real-world evidence, please scan one of the QR codes here or visit the VEKLURY website at vekluryhcp.com.